workshop and come back and then you have to use something from that. So firstly, that you need to first target what are the things that you need. You need the discipline in the family, you need all of those things pre-implant. And articulation is not something that I'm bothered about. Children also, even if you say normal hearing children, they'll first start with individual words, then they'll go on to jargon. They'll go things like that. So that is jargon, that is all communicative intent. So I'm looking at that. From the children at our center who came to us at say 1 year of age, were implanted at say 2 years, 9 months of age also, we found that even with an implant it takes roughly about 2 to 3 years. And we don't do any speech correction. It comes via listening, via exposure. So I'm not going to sit down there saying, "Tumne ye saaf nahi bola." It doesn't happen. So I mean, it's a typical example. My mom tried to learn Marathi, and I would laugh at her incorrectly. So why? Because she would not be able to say that as in parts, tujha. She couldn't say, and she would say tujha and part and all that. So she finally told me, "I said I gave up Marathi because of you, because you laughed." So I mean, that's really sad. And that's the same thing, I mean, she's an adult. What does it do to the child's self-esteem? So we shouldn't be bothered about speech really. First think about language coming up. Yeah? Thank you, ma'am.
Any more questions? No. We'll start the section.
Good afternoon, everybody. I'm sorry for the delay. And my today's presentation is on late cochlear implant recipients and cochlear implant children with additional problems, their expectations and outcomes. Now, there are several factors that influence the progress of a child with a cochlear implant. These are 3 classic cases. Just I would like to make a mention about this first child. He has got deaf parents. He has been implanted at a late age, but he has got deaf parents too. So, you know what his outcomes would be. The second child, though he was implanted at an early age, got a surgery done in States and he was mapped in States, and his mapping, I mean, there were some issues, there was no development seen in this child until and unless we coaxed the parents to have him mapped in Mumbai, and now the child is steadily progressing. And this third child, she has parents who both of them don't speak a common language. So there is, no steady input, definite input to the child. Now, the various factors that would affect would be the onset of hearing impairment, age of intervention, age of implantation, previous auditory experience, the presence of other learning handicaps, teaching emphasis on auditory learning, and accurate mapping. Now, there are several factors. Now, these are children who have come to us at a very early age, though they were they were not cochlear implant recipients at the outset. They were fitted with appropriate hearing aids, and they were into an auditory verbal program right from the time they were young babies. They received implants at a later stage, but they have been doing well now even after they have got an implant later on in their life. Because now this is very important, though they've got an implant later on, but their previous auditory experience, what they had with hearing aids, really helps them to develop further. Because though we say that the child could have done well with these hearing aids, but that the hearing aids were limited, their language was not progressing as it should have been. These children had plateaued to a certain extent, and so they had been fitted with hearing aids, good hearing aids, but they were only good in one-to-one conversations. There was difficulty in noisy situations, and incidental learning was absolutely not there at all. But once they received their cochlear implants, they started listening all the new sounds that they were not hearing earlier, and so that they could integrate all these new sounds into their language, and they made very rapid progress. And also, once they had a good amount of speech and language when they got these cochlear implants, so they could even learn to self-monitor their speech problems. And now their progress in speech and language both is very commendable. Now, these are children who have been fitted with hearing aids at a very early age, but have been in a lip reading and an auditory training program. Now, though these children have been identified earlier, but due to certain reasons, either due to that they have been in a different program or due to a not proper selection of hearing aids, they really did not get the benefit of the amplification device right in the beginning. But then later on they were implanted. So with these children, we have to keep in mind that they have come in from a visual program. So when the cochlear implant is switched on, we have to remember that we have to give them certain visual clues. So our approach will have to be auditory, visual, auditory, so that the child gets the boost of his earlier experiences, and that will also help him to advance further. Also, it is very important before we select these children for a cochlear implant that we should know as to what the child is able to hear through his hearing devices, at least auditorily, because at least it's not very easy to say, okay, he can hear throughout the speech frequencies or not hearing it. But we should know as to what is lacking, so that this will enable us to decide on the candidacy of the child and to set realistic expectations with the parents. And also, last but not the least, if there are any mapping issues later on, so that though you can see theoretically the map is very good, but the child is still not processing certain sounds, so it may be due to some other reasons rather than just being a mapping issue. And so when, again I emphasize here that whenever the child is switched on, we just can't put him onto an auditory program. Here our approach has to be visual auditory, auditory, visual, auditory. Now this is late diagnosis and intervention. Obviously when there is a late diagnosis, this would result in poor speech and language development. All these children who are seen here, they have been diagnosed at a later stage and they have received a cochlear implant. Though they are making progress, but yes, their progress is limited. But this progress they would never have achieved with their hearing aids. Now, congenitally deaf teenagers and young adults. Now these, again I would just mention a brief, like this girl, she was implanted at the age of 12 years and she is mentally subnormal. And when she came to our institute first for an evaluation, we have advised her not to get a cochlear implant, but somehow the parents were very pushy and they got an implant done and they came back to our center for the rehabilitation, because ours is the only center who doesn't refuse any children. So we had to accommodate her, though we don't see her at our center, she's seen elsewhere. This child is doing well in terms of that she's become very much confident of herself, because now she's able to hear everything that she was not able to hear earlier. But yes, the speech and language development is not as much as that could be expected, and this was explained to the parents. However, I would again make a comment here that no doubt, no matter how much we counsel the parents pre-implant, that what the outcomes would be, parents become greedy the moment they are switched on, and then they are not happy with whatever little progress they achieve. They want more and more and more. Now this second boy, he got implanted at the age of 22 years. But he was already into an auditory program right from the time he was a baby. And he made maximum use of his hearing aids. He was using his hearing aids till the day he got an implant. So definitely when he got an implant, he had these issues that it was not sounding the same as his hearing aids, and there was a little bit of hesitation on his part to accept the implant. But moment as he kept on using the implant and we kept on counseling him, now he is a very good user of the implant. In fact, I joke with him that can we trade off your processor with the hearing aids, and he says no. He's able to hear very well now with the cochlear implant. And this third boy, even he got implanted at the age of 22, but here he came to us from a signing program, and he had stopped using hearing aids after the age of 10. And though we were not very keen on getting him implanted, but he was highly motivated. He had seen other cochlear implant recipients, and so he just wanted to get one done. And he understood the limited outcomes with whatever limited language he had. And today he's got a cochlear implant. He is able to hear everything in his environment, But yes, processing language through audition is difficult, because we should know that these children are will never be able to process language only through audition. They are going to make use of other clues also. Now, these are, this is a slide of postlingual children and postlingual adults. Now, all these children have come to our center, after they have been diagnosed, and the benefits of a cochlear implant would highly depend upon what was the time lost between the hearing impairment and the cochlear implant done. And because they've had their earlier listening memory, it is not very difficult for them to do well with the cochlear implant. So all these 4 children are really doing very well with the cochlear implant. Now, some multiple problems which affect the success of the cochlear implant. As we all know that it is very less, we see very often that we don't find children only with hearing impairment. Each child, when we really evaluate the child in depth, we find that there is some amount of other problems that are present. So it is very, very essential that we get to know of these problems either pre-implant or even post-implant, and then the necessary the steps should be taken. The other fraternity should be involved into the therapy program, and suggestions and strategies should be exchanged between professionals so that the child makes maximum use of his cochlear implant. Now, some multiple problems that would affect are cerebral palsy, mental retardation, autism, attention deficit disorder, attention deficit hyperactivity disorder, Usher's syndrome, and dyslexia. So therefore, it's at least mandatory at our center that we get before an implant, we get all the necessary pre-implant evaluation done, at least the visual evaluation, even the psychological evaluation done, so that we can plan out as to what would be the outcomes. And so the parents are informed in advance as to what they should expect after the cochlear implant. And there will be other learning disabilities too. Now, there is another factor that may affect the success of a cochlear implant, but these need not be only due to late implantees. This could affect even any other recipient of a cochlear implant, that is partial insertion of electrodes due to a partially ossified cochlea, or a malformed cochlea, or a Mondini syndrome, or a surgical error. Here I would just like to mention that this boy, when he was in our program since he was a baby, and he was fitted with hearing aid, but he made very limited progress. But once we were deciding on the candidacy of an implant, and when the CT MRIs were done, it was a shock to us when we realized that he had an absent cochlea in one ear and he had a malformed cochlea in the other ear. So, this, at least when we were evaluating him for candidacy, we got to know as to what was the impeding factor. And this boy, he has been implanted in a private clinic, and where he developed infection. So then the implant had to be removed, and again he was re-implanted, though now he is doing quite well. And this boy, though he was implanted at the age of 2 years, but he was implanted with a single channel implant, and because he was not progressing, and there was, we tried to find out why he is not doing that, and when an X-ray was done, we found that the implant was in the eustachian tube. And so again that had to be removed, and this child was implanted again, and now he's doing well, though a lot of time was lost in that period. So yes, today he's not as good as his other peers. Now, speaking of guidelines to an auditory approach for the rehabilitation of late implant recipients and children with multiple problems. The most important is early detection and intervention to make maximum use of the critical windows of learning. Now you've been well versed with this aspect of critical windows in these last 2 days. I mean, you've been told what the importance of the critical windows. So that in itself is very significant enough that we should detect and intervene at the right time. Now, good audiological management is again very crucial, because either when whatever amplification device is advised, either hearing aids or a cochlear implant, has to be appropriate enough, and followed by very effective habilitation. So that it's not very, I mean, it's easy just to get an amplification device, be it hearing aids or a cochlear implant, but if it is not followed by therapy, it doesn't mean anything. So therapy is very, very crucial. Again, all the speakers have emphasized on parent participation. Just now when Geeta mentioned about it, parent participation is very, very important, because we have to empower our parents to become the primary facilitators in the development of their child's listening skills and spoken language. Because as Geeti pointed out, that the parents are with the child 24/7, we are with the child only for a couple of hours in a week, or more than maybe 3 or 4 hours in a week. So really we can't take them forward as much as the parents can do. And therapy should be structured as well as incidental, and it should be ongoing throughout the child's waking hours, because if the therapy is incidental, it involves all the daily routine activities what are taking place in the child's life, and it is again easier for the parents to incorporate the structured part of therapy into their daily routine activities. That's a must, because whatever we do in a therapy session may need not be transferred at home unless the parent is smart enough or is shown how to take it forward at home. And it is very important to provide an auditory environment that will support listening for the acquisition of spoken language. So, and it is also important to have good acoustic conditions in the initial phases of learning to listen, because when the child receives a cochlear implant, he is familiar with all the sounds that are present around him. But if there is a background sound, and that would really hinder as to what he is listening. For example, at home when the parents are talking to the child and then there is a TV that is going on in the background, that would really hamper as to what is happening. It's except like when they are watching TV together, that's a different thing. But if they are trying to talk to the child when there is a TV going on in the background, I think those noises should be kept to a bare minimum so that the child is able to learn to understand speech and language better. Now, one-to-one therapy, that's the most important part, because each child is different. No two children you will find, though they may be of the same chronological age or at the same level of functioning, but one-to-one therapy will enable the rehabilitationist to find out as to what level the child is, where to take this child from this level, and also this gives them time to spend with the parents as to guide the parents as to the future course of action. Again, as Geeti mentioned, that on administering of formal and informal diagnostic assessments to monitor progress and to develop individualized therapy plans for the child and family is very, very essential, because unless we have some diagnostic tools, it is very difficult to take the child forward. Integration. Now, because the children have been fitted with cochlear implants, they should be mainstreamed with their normal hearing peers. But sometimes, because they have been late implantees and their chronological age has really surpassed their hearing peer age, so it is difficult sometimes to mainstream these children into a regular program, because schools are really very stringent on their admission. So sometimes we have to make a choice when they are staying into a special program. Now, because since they have been late implantees or children with multiple problems, you know that though they may be using sign language and lip reading earlier, but we should be able to enhance their listening skills to their maximum potential. That should be our goal. And last but not the least, teamwork. That is very, very important. That we should have a partnership of parents, teachers and audiologists and with the ENT surgeon who is operated, so that we can effectively deal with any issues that the child is facing. Thank you.
instead of the customer. The next speaker is D3. She's talk about the importance of counseling and expectation.
She mentioned, they are the children with the implantation who is having ADD or ADHD. So, do they really hyperactivity due to profound deafness, or how the diagnosis was made and everything?
See, we all know that the children are hyper because of their deafness, but once they are fitted with proper amplification device, be it hearing aids or a cochlear implant, they settle down. But if we find that yes, they are not settling down, so definitely we have to send them for an evaluation and seek in necessary measures. Because, and as a rule, even when we send them for an evaluation, so in the evaluation sheet it does come in that the ADT could be due to the hearing impairment. So we definitely wait for some period before we start with any active intervention.
So you had the children, who had really hyperactivity disorder, or the hyperactivity due to this profound deafness?
It could be both. Yes.